Abnormalities in gait. Human gait is a complex interplay of the nervous, musculoskeletal, and cardiorespiratory systems. The gait pattern is influenced by age, personality, mood, and sociocultural factors. The gait cycle has 6 phases as shown in the diagram. Gait disturbances are described as any deviations from normal walking or gait. Etiology involves diseases of the neurological system, electrolyte imbalances, severe vitamin deficiencies, and chronic pain. Hemiplegic gait. A hemiplegic gait is caused by stroke, space-occupying lesions, trauma, and multiple sclerosis. Exhibits as unilateral spastic flexion of the upper limb and extension of the lower limb. Due to the extension of the lower limb, patients have to circumduct their leg to prevent their foot from dragging on the ground. Diplegic gait. Diplegic gait is also called scissor gait or spastic gait, caused by bilateral paraventricular lesions, such as cerebral palsy. Bilateral spasticity is worse in the lower limbs. The knees are forced together, leading to scissoring. To overcome this, the patient circumducts both legs during the swing phase. Flexor posturing of the elbows and wrist with shoulders and fingers in adduction is known as low guard or mid-guard position. Parkinsonian gait. The patient will have rigidity and bradykinesia. The patient walks with slow little steps, leading to shuffling gait. Presence with difficulty in initiating steps, showing an involuntary inclination to take accelerating steps, known as festination. Seen in Parkinson's disease. Ataxic gait. Seen in cerebellar disease, described as clumsy, staggering movements, with a wide-based gait. On standing still, the patient's body swaggers back and forth, and from side to side, known as titubation. Patients will not be able to walk from heel to toe or in a straight line. Acute alcohol intoxication will resemble this gait. High-stepping gait. Seen in patients with foot drop, caused due to an attempt to lift the leg high enough during walking so that the foot does not drag on the floor. If unilateral, causes include peroneal nerve palsy and L5 radiculopathy. If bilateral, causes include amyotrophic lateral sclerosis, Charcot-Marie-Tooth disease, and other peripheral neuropathy. Waddling gait. This gait is seen in patients with muscular dystrophy. Hip abductor weakness results in an inability to stabilize the pelvis during the stance phase. As a result, the pelvis tilts downwards towards the unsupported side during the swing phase of the gait cycle. Positive Trendelenburg sign is noted when the patient stands on one leg, the pelvis drops towards the contralateral side. Choreiform gait. Choreiform gait is caused due to basal ganglia disorders including Sydenham's chorea, Huntington's disease, and other forms of chorea, athetosis, or dystonia. The patient will display irregular, jerky, and voluntary movements in all extremities. Walking may accentuate the tremors. Antalgic gait. An antalgic gait develops as a result of pain. Typically, the stance phase is reduced on the affected leg, resulting in a limping appearance. Causes include osteoarthritis, inflammatory joint disease, lower limb fracture, and nerve entrapment, for example sciatica. Stomping gait. Sensory ataxia, or stomping gait, affects patients with significant proprioceptive loss. Characteristically, the patient looks down and walks as if throwing his feet, which tend to slap on the ground. Seen in peripheral neuropathy. Hysterical gait. This bizarre gait is seen with hysteria conversion reactions. While walking, the foot is usually dragged or pushed ahead instead of lifted. Frequently, the foot is held dorsiflexed and inverted. To get more such high-yield medical content, don't forget to subscribe. BasidiaMED. The easiest and fastest way to take advanced clinical history.